Mariana Rucker, Diversity and Inclusion Committee Chair of the Beverly Hills Bar Association Barristers Section, and I'm delighted to introduce today's speaker, Maryjane Duquette. Maryjane Duquette is a healthcare professional with over 18 years of experience, including the last decade as a registered nurse across diverse settings such as medical, surgical, pediatric, triage, outpatient, and home healthcare. She has extensive expertise in clinical documentation, having worked with both paper charts and electronic healthcare records throughout her career. Currently, she serves as a nursing instructor at St. Joseph's College of Maine and a nurse consultant, aiding legal teams by interpreting medical records for both plaintiff and defense cases. And without further ado, let's get started.
Hello, everybody. So as she said, I'm Maryjane Duquette. I think I'm going to just skip introductions and just jump right into it. So the nuts and bolts of medical records for personal injury cases is what we're going to go over today. So some of the objectives that I wanted to incorporate for you all is I want to go over the different types of medical records because there's a lot of different styles that you'll see. I plan on breaking down and learning the different parts of a medical record. So the goal here is for you all to know if you're looking for a specific piece of information, you could have a record that's 5 pages or 10 pages long. So narrow it down to exactly where and pinpoint where you would want to go look for that piece of information you're looking for. Learning how to read records efficiently. Since I do a lot of medical records reviews, I've got a lot of tips on how to kind of get through thousands and thousands of pages a little bit more efficient. And so I'll share all of my tips that I use with you. Learn effective ways to review large volumes of medical records, kind of ties into the one before. Learn how to identify missing medical records. So this can be a bit of detective work. It's not always obvious what providers a patient has seen. Sometimes there's recommendations, and then how do you know if they've been there? So I will share all of my tips that I use to find missing medical records with you. And then at the end, we're going to touch on some of the issues that I notice, touching on issues with handwritten documents, and then also some issues with medical records tampering, which can come up sometimes in certain cases. More so with medical malpractice. I've seen it as an issue, but it's good to be able to pinpoint some things out so that you know. I'm going to skip my introduction. It's there for you guys to look at later. Okay, so just in general, in a personal injury case, some of the medical records that I would expect to see as a nurse, and that any of your medical providers would want to see, whether it's an orthopedic surgeon, pain medicine doctor, any of your experts or treating physicians would want to see. So if there was an ambulance, you'll want to know you'll want the ambulance records. There can be two sometimes. Sometimes you can have the fire department will show up first, and then you'll get the ambulance service with the paramedics that come and actually transport the patient to the hospital. This includes air flight, so if they had to be airlifted somewhere, you'll want to know that and have those records. The next set of records, if they've been to the hospital in urgent care, you'll have hospital records. Those can include emergency department records, any kind of consultation. So if there were broken bones, you'll probably have orthopedic surgery. If they had a massive bleed, you might have vascular surgery. There's nursing notes and flow sheets if you really need to dive into vital signs or changing in status and things like that. But for the most part, I focus a lot on the provider progress notes and consultations. There's also operative reports and things like that when they're in the hospital. After the hospital, a lot of patients might go to a rehab facility if they're not strong enough or able to take care of themselves at home. So you'll want to get those records as well. For this webinar, we're not really going to dive into those records specifically, but those should be, and a lot of times if they've been to the hospital or been admitted, those should be a part of what you're going to gather. The next type of records you will see are outpatient. office visit records. These can be primary care records, orthopedic surgery, neurosurgery, pain medicine, anybody that they've seen outpatient, going in doctor's visits once they're discharged, all helpful information. Outpatient surgical records, so maybe they've gone for operations as an outpatient, maybe they've gone for pain management interventions like spinal injections, nerve blocks, things of that nature. You'll want to make sure you get all of those records as well. And then, of course, there's therapy records. So really helpful to know because those therapy records and visits can really add up over time. So if you have physical therapy, occupational therapy, chiropractor visits, there can be a lot of visits. And so it's really helpful to be able to get a hold of those records. As I said, our focus for this webinar, because of the nature of it being personal injury, the bulk of the personal injury claims, most common are going to be outpatient records. So that's what we're going to focus on. A lot of the stuff like what parts of the medical record we're going to go through can really help you look at the inpatient records as well. So you can kind of use all this information for all of it. There's just a little bit more nuance to the inpatient records and a lot more detail. So we'll focus outpatient, and we'll go from there. All right. So the part of a physician's note or a nurse's note or a therapy note, they always have this format. It's called a SOAP note. This is kind of the basic bare bones skeleton of the note. You'll see different things added in. Every provider is going to have their sections, depending on what they're looking at, their assessments. Things will look a little bit different, but it's always going to be in this sort of format. So you'll have the SOAP stands for subjective, objective, assessment, and plan. So the subjective information is really, and you can see it here. So it's kind of what the patient tells you. And we'll go into detail on all of these. I just want to give you a quick overview. Subjective information is more what the patient tells you. What are their symptoms? Objective information are like vital signs. Assessment is more the physician's assessment. And then the plan is, what the treatment plan is. I've got on the side of the slide here kind of like a bare bones outline. I actually use this for my nursing students when I'm teaching them how to build a SOAP note. So it's very, very basic, but it kind of gives you an idea of, if you wanted to know how the patient's symptoms were progressing, you would know to check the beginning portion of the doctor's note because it's going to be in there somewhere. If you were looking for the plan and future recommendations, it's probably going to be at the bottom of the physician's note. So if it's a 5, 6, 7, 8 page note and you're looking specifically for plan information, to go towards the page 6 or 7 instead of having to go through all of the information. So deep dive into the subjective. So this is where the provider is going to put, like I said, any information that the patient tells them. So the patient comes in and says, I was in an accident on this day and I now have neck pain and back pain. And then the doctor will ask some more questions. How bad is your neck pain? Does it hurt to, what can't you do? Can you dress yourself? Can you bathe yourself? Can you go to the grocery store? Can you lift grocery bags? All of this information that the patient it's coming out of the patient's mouth. It's not things that we as healthcare providers can measure. It's just what the patient is telling us. That's going to be in your symptoms section. In your subjective section. You're also going to find any information on previous treatments. So say they've gone back to pain management and previously they saw neurology or a neurosurgeon or they've started physical therapy, the doctor will usually ask them those questions and then put like a line in there, patient has begun physical therapy at this time. So we'll know what treatments they've had since the follow-up visit if the doctor knows. And then any other relevant information that the client provides. Sometimes that can be, You might find information around have they returned to work? Have they returned to work and they're struggling working? Are they asking for a doctor's note to be out of work? Are they needing a handicap placard? Are they needing any new equipment, any medication refills? Off the top of my head, that's pretty much the information. So I would say if you're looking for any information that your client has around symptoms, limitations, how they're doing outside of that, any previous treatment or any treatment that they're planning to go to, the subjective, the beginning of the note is a great place to start to look at. The next section is, and a lot of people have a hard time with the objective and the assessment section, but the objective section is on objective measurable data. So this is when the nurse gets the patient in the room and takes vital signs. You'll find this here. So if you're looking for, let's say, one thing that we can do as nurses and providers is if a patient's telling us that they're in a lot of pain, one thing that happens when you have pain, one of the responses is that your blood pressure goes up. So if we've got a lot of data on a patient's blood pressure, say before an accident, pre-morbid records, and they had a really normal blood pressure, and then after the accident, or even if they had their pain controlled and it suddenly wasn't, you could see a spike in a blood pressure. And so this is the section, the objective section that we would go to. Any vital signs data, sometimes they'll put include in there the pain scale. So we always ask patients to rate their pain on a scale of 0 to 10. And so we would put that information in there. One thing I like to say about the pain scale is that it is kind of subjective. So you could find it in the subjective section or objective. It just depends on. There was this movement in healthcare where they were using pain as a fifth vital sign. So they would include it in with the vital signs to ask at every visit. So it depends on where you'll find it. But the issue with the pain scale is that it's grading the pain on the patient's experience of pain. So somebody who might have had, like an amputation or childbirth or something really that we perceive as really painful, and that could be their level 10. Someone else, their worst pain that they've ever felt might be like they skinned their knee or they got a paper cut, right? And so I'm sure they wouldn't say that was like a level 10, but their gauge on a scale of 0 to 10 might be a little bit different. So I try to tell patients and I try to tell nurses when they're kind of going through this assessment to let people know that it's based on your level 10, because if a level 10 out of 10 pain is, I'm not sure you could be able to talk or speak or move, that's really super uncomfortable. And so whatever that feels like, if you're feeling like that, that is your level 10. It doesn't matter if I felt worse pain and my level 10 is higher, if that makes any sense. Other things you'll find in the objective section is lab data. So sometimes patients get infections and that complicates their course of treatment. They could have a wound open from a burn injury or an accident and an amputation we're trying to heal, and now it's infected and we got to worry about treatment and it's going to prolong their care. So you'll find culture data, lab data in this section. Imaging results. So if they've gone for CT scans, MRIs, X-rays, anything of that nature, you will you can find that out. And then any specific testing that the provider did. So they might have gone to neurology and maybe the neurologist did some muscle and nerve conduction testing. They might put the results in there as well. Sometimes they'll go for pre-op visits. One of the hallmarks of a pre-op visit is an electrocardiogram to make sure that their heart's functioning in a way that, they can have anesthesia safely. And so you might find that information in there as well. And just basically any objective testing that they've done. So no real interpretation on this information. This is just the raw data that you can use in here. I will go for a little tangent that I find helpful when I'm explaining imaging results to people. One of the things that you notice when you have an expert working on a case, you get an orthopedic surgeon or even just a nurse to review your imaging, there's a certain, we can anticipate sometimes some of the treatments that should happen. So if somebody says so-and-so has a fracture, I'm gonna be, well, they must have done x-rays, right? They have to diagnose that somehow. They might say that they've had a brain bleed, and I might see that somewhere in the records. Well, I know that they must have done a CT scan or an MRI to be able to diagnose that, because you can't tell just by looking at, so you can tell their symptoms, but you don't really know what's going on. And so you'll want to know. And so I like to tell people when you're looking at what imaging you should be looking for, it's helpful to know what the imaging can kind of what it can do. So x-rays are really good at looking at bones, because what it's doing is it's sending rays through the body. And what happens is if it bounces off a solid object, it slows down. And if it goes through, if it doesn't hit a solid object, it goes faster. So when you're, like, say you're looking at an x-ray of the chest, you'll see all of the bones will be white because the x-ray slowed down, and they kind of got stopped and blocked by the bones. But then you'll see where the air spaces are, which essentially is the lungs. That looks really dark because the x-rays have just gone straight through. So an x-ray isn't really good at looking at soft tissues very well. It can do some, like orthopedic surgeons can pick up some bleeding here, in a joint or something. But for the most part, an x-ray is really great basic looking at bone structures, so like fractures and things of that nature. And then you'll upgrade to a CT scan, which kind of does the same thing, except a CT scan, instead of going through the body, a CT scan kind of cuts sections, kind of like transverse. So like through the body, instead of like looking at the image like it was a picture, you're going to see slices internally of the body. And so this one can show you bone structure just as well, but it can also show you organs and some soft tissues and things of that nature. There can be contrast studies. So if you're looking for bleeding, you might want to look for if there was a contrast study done, because then they can kind of see where the contrast has gone, and if there was leaking from a blood vessel, that indicates bleeding. And then the most common one is an MRI. MRI is the most sensitive to a lot of the soft tissues. So you'll see that they'll need MRIs of the brain, because it's all soft tissue aside from the bones of the skull. And then you'll see a lot of MRIs needed of the spine. And that's because we can see not only the bones in the spine and the discs, but we can also see all of the ligaments and the structures that are coming off of the spine as well. So that's your objective section. That's the overview of what you'll find there. Some specialties, you'll have other things, like if you've got someone with a rib fracture, they might have gone to a lung doctor and they've done pulmonary function testing, right, to see if they can take deep breaths and how they're breathing, because they have the rib fracture. So there can be very specific nuances, but these are the most common things that I see in this section. The next section of the general physician's note or progress note is the assessment section. So this is where the provider has actually laid hands on the patient and they have done their assessment. You will see that each specialty does a different version of this assessment. So you might have a family medicine doctor who does more of a general assessment. So they're going to look at the heart, lungs, abdomen, neurologic system. Are they alert and oriented? Kind of overall. And then if the patient complained of back pain, they might add a blurb in there about the back and do a quick high-level assessment of the back in a family medicine visit. But for the most part, in a general assessment, you'll get kind of an overview of the whole body system. If you go to like an orthopedic spine surgery or neurosurgery, you're going to get a spine assessment. So they'll still do the heart, lungs, abdomen neurological assessment, but they'll get a little bit more detail into the spine. So they'll do, look at the appearance and see if anything visibly when they're looking at the patient's spine. So they'll look at their neck and see if anything looks off. So are there any deformities or are there any areas of step off? You'll see that term commonly. Step off means that there's a misalignment of the spine. So the spine's kind of been one of the vertebrae's been a step off, kind of came off of it's out of alignment essentially. They'll look at range of motion. So looking at the necks, can they extend? Can they flex? Can they bend it side to side? Can they turn their neck? They'll do the same thing with the thoracic spine and the lumbar spine. They'll palpate. So they'll palpate the neck bones to see if they're tender, but then they'll also palpate, which is kind of feel and kind of poke on and see if they can elicit some tenderness in the muscles around the spine. Because if you've got a ligament injury or a soft tissue injury, your muscles in your neck can be really tight and really sore, but it doesn't necessarily mean that your actual bones in your spine might be an issue. You'll usually see extremities assessments. For in a spine, like orthopedic surgery, you can see more of function sensation. So what's the strength of the forelimb? So if you have a neck injury, you definitely want to know how strong the arms are. Do they have sensation in the hands? That way we know we can detect if there's any nerve damage based on that. And then if you see just an orthopedic spine, so say you have a leg fracture, they're gonna do a detailed assessment on that leg fracture, right? So the appearance, is there any deformity? Is there tenderness? What's the range of motion? You'll see things like neurovascularly intact. That means is there movement? Is there blood flow? Is there sensation? So if somebody fractured their knee, we're gonna want to look at the foot and see if it has blood flow, sensation, and if they can move it, because then we can kind of know that the nerves and the blood vessels aren't damaged as well. In this assessment, a lot of times you'll see a gait assessment. So if somebody's complaining of back pain, they might walk with a gait. You'll see some gait abnormalities. So how are they walking? Are they walking with a limp? Are they not able to stand fully up? Are they kind of walking slower than normal? You can get a lot of information about somebody's gait and their pain, essentially. And then the thing is that every assessment, it always has that general portion, but it just depends on which provider you go to. There's some like psychiatric and things that are a little bit different, and we'll touch on those later. But this is kind of the overview of the information that you're going to find. So if you wanted to look at your client's range of motion over time, you could look at this section of the note and kind of look at what their range of motion measurements were the first visit versus the last visit. And then you can kind of see if they've improved or not in the course of treatment, just as an example. Okay, and so the plan section is where you're going to get a lot of, so the doctor has asked the questions, knows how the patient's feeling, they've gathered their data in the objective section, and then they have done their assessments themselves and gathered, so they have all the data they need to treat the patient. The plan is the treatment. So are they recommending medications? Did they recommend any therapy, chiropractor, physical therapy? That should be in this section. Are they recommending any surgery, procedures? That can be helpful. A lot of times the doctors also, which I find is really helpful, is they'll put estimated costs in this section as well. So that can be really helpful and cut down some work kind of guessing on how much, a surgery for like a settlement purpose or something. The doctor will have that in there. When should they follow up? Or do they need to follow back up with that provider? Sometimes they'll say, they'll have surgery have a few follow-ups, go through therapy, patient's feeling better, they'll say follow up as needed. And then so we wouldn't necessarily be looking for further records from that provider unless we were informed in another way, which we'll go over, that they went back to see them. Or does it say to follow up in 4 weeks? And then we know to look in 4 weeks, did we get medical records for that as well? And then also sometimes you'll see future medical recommendations. This usually comes when the patient is near being discharged from that provider. So say, like in the example of they've had orthopedic surgery for a shoulder injury, doctor did surgery, and then they've gone through their post-op therapy, they've gone through a handful of post-op visits, they're going to be released from care. Well, the provider sometimes will write information in there to say, hey, the patient might have some flare-ups, and this is what we might expect for medical care going forward. If they've had a flare-up. If a flare-up happens, we might think medications. If a flare, they might need a course of physical therapy. They'll outline kind of what their recommendations are. So all of that information can be super helpful to find in there. And then kind of like a note. So like I said, there's lots of different specialties. The most common ones in personal injury that I see are neurology, more for your brain injuries, sometimes nerve injuries. You'll see a neurologist to get those muscle and nerve conduction studies done. Orthopedic surgery, they're going to be for broken bones in general. A lot of them will specialize. So you'll have some will be, they might only do knees and hips. Others might just do shoulders. So just kind of knowing your orthopedic surgeons, but that's more basic bone injuries. And then orthopedic spine surgery and neurosurgery. I think if you had an orthopedic spine surgeon and a neurosurgeon in a room, they'll tell you all of the differences between them. But essentially, for my purposes, and probably yours to kind of look through and read the medical records, they kind of do the same thing. They do spine surgery. Neurosurgery sometimes can do brain surgery as well. That's a big difference there. But as far as like spinal injury, they kind of do the same. Pain medicine or pain management, it kind of depends on the provider. They might say that. So that's a fairly new specialty in medicine, where we're kind of trying to get away from opioids because they're highly addicting and, as it turns out, not very good for people. And so we have this new branch of medicine that is run essentially by, a lot of times it's like anesthesia does it. So an anesthesia doctor, because they do a lot of nerve blocks, so they can inject anesthetics into the spine and then they can kind of block a nerve. So essentially the premise is that the nerve is what makes you feel pain. So if you block the nerve from doing its job, then you can't feel the pain. You'll see lots of different spinal interventions with them. They can prescribe medications, although some of them don't. Some of them will do surgical interventions with the spine blocks and things like that, but they won't prescribe ongoing medications. They'll send them back to like their primary care doctors to do that. And then you'll have physical medicine and rehabilitation. So a lot of times those guys are all around rehabilitation. So you might see them as like the main hub in treating somebody with a kind of a bigger injury. They might be the ones to order therapy. They might be the ones to send them to specialists and recommend, I think this patient needs to see a neurologist. I think we need to do therapy. That's kind of their wheelhouse. So it's a doctor that kind of goes over how the patient is rehabbing. So how are they getting back to their function, back as close to prior level of function before the accident as possible? That's always the goal. You'll have psychiatric notes. So psychiatric providers, psychiatrists, they can prescribe psych meds. So these are really great people to send your patient to if you need to have like post-traumatic stress disorder, anxiety, depression, kind of get them evaluated for those interventions. And also they understand those psychiatric medications and can treat them a lot better. Psychotherapy, so this is with either a psychiatrist or a social worker, a licensed clinical therapist. They can do, it's kind of more talk therapy, or you'll see cognitive behavior therapy. A lot of times that'll be out there for you. And then there's neuropsych. Sometimes people get like psychiatry and neuropsych mixed together. Neuropsych is more psych for function. So how are they doing? So if it's a child, they can do like their math and reading, or even just anybody and get their, how are they functioning in the world? Or do they have the capacity to manage their finances? Do they have the capacity to manage their everyday lives? Is it a child or somebody thinking about going to school? How are they going to keep up in school? They might they might be able to diagnose ADHD, which is attention hyperactivity deficit disorder. They can diagnose PTSD as well, and other things, but it's more of a function-based psychiatric kind of assessment and tool than just the psychiatry. That's my understanding of it anyway. I'm sure a neuropsychiatrist would give you like a lot better explanation there, maybe a little bit more in depth. And then we have sleep study notes. So a lot of times for sleep study, patients that have maybe had brain injuries, they might be having difficulty sleeping, not feeling rested, and sleep is really important for function. So sometimes patients will get sent for a sleep study to see how they're doing. Do they have sleep apnea now that they've got, central brain damage? Or have they gained a lot of weight? That can cause sleep apnea. Or a lot of times these sleep studies can also give you feedback on the quality of their sleep. So if they're complaining of poor sleep, you might see a sleep study in the mix there. The next thing I'm going to do is go through the therapy records. I kind of broke them down because a lot of the like physical therapy, occupational therapy, even healthcare providers have a really hard time deciphering what each specialty does and what you should be looking for when you're reviewing the notes, right? Like on your end. And so I was going to go through those each. This is just my little brief slide here. Okay. So start with physical therapy. So when you're thinking physical therapy, think that they work on mobility and larger muscle groups. So like your legs and your back muscles. That's not all they do necessarily, but like that's kind of the big overview. Mobility, larger muscle groups. It's a form of non-invasive medical care. So this can be done in place of surgery or try to avoid surgery. Sometimes you'll see the surgeons will say, hey, try physical therapy. And then if your back still hurts, we'll talk about doing something more invasive, which means a procedure, a surgery, more medical care. And so this can be done, like I said, before surgery. It can be done in conjunction with surgery. So a lot of times they might say you have a hip fracture that needed to be repaired. They're always going to have physical therapy. They should always make sure that you're getting physical therapy notes. I've never seen anyone have a hip surgery and not have physical therapy after. It's often ordered in a course of anywhere from 1 to 3 times per week, although 2 times a week is what's most common, and for courses of 6 weeks. So the therapist will order in the beginning, 2 times a week for 6 weeks, and then they'll reassess the patient. If they're still making progress and they're not where they want to be, then they might ask for more visits. Or if they feel like they've made progress but kind of hit a plateau, they might discharge them and they'll go back to the doctor and kind of go from there. One course of therapy can occur, but patients might have a course of therapy and then later on get a flare. And so you might have another course of therapy later on down the road. When in the context of medical records, when you are looking for physical therapy, the things that I try to pick out from these records are the patient's functional deficits. So some common things are, they'll have decreased strength. They'll comment on their balance. They'll comment on range of motion. They'll comment on sensation. deficits. They'll comment on their ability to perform, we call them ADLs, activities of daily living, which are kind of your basic things. So can you eat? Can you feed yourself? Can you dress your lower body? Can you put your pants on? Can you put your shirt on? Can you put your shoes on? Can you transfer? Can you get out of bed? Can you roll in the bed? Because some people that are really injured and really either in pain or weak, or depending on their injuries, they can't even roll in bed without help. So kind of all of these functional deficits you can really get from the assessment portion of the physical therapy records. They will also recommend if there's equipment. So say your patient or your client needs a walker or needs a cane. Physical therapy is often the ones who recommend we call those assistive devices. So they'll recommend those. They could recommend any kind of grab bars. If you had home health physical therapy, they'll talk about modifications to a home that need to be made. Lots of different equipment recommendations you can pull from physical therapy records. You can also get details about their prior level of function, because the goal of physical therapy or any therapy is to get them as close to their prior level of function as we can. Hopefully, we can get them to their prior level of function, and then they don't have any issues moving forward. That would be ideal in every situation. But we always need to know where they started from and what our goal is, right? You can also get details about their home. So do they live in a single story home? Do they have stairs to enter? If they're wheelchair bound and there's stairs to enter, we're probably going to have to think they're going to need a ramp, right? How are they going to get in and out of the house? Different information like that. And then you can also get the tolerance to therapy. So how are they tolerating therapy? So yeah, they're going every week, but are they able to fully participate? If not, is it because of pain? Is it because they're too weak? Sometimes that can be really helpful information. Some other information you can get from physical therapy notes are if they've seen any providers, they might say, oh, they saw their orthopedic surgeon and they're going to have surgery next week. And you might not have gotten the orthopedic surgeon's record. So now you should be looking for those records, and there was surgery that was going to happen the next week. And so it'll alert you to make sure that you're following up to get those records and see what happened. And then they also do future recommendations, right? So as far as physical therapy, so are they recommending, have they reached a plateau in therapy? Are they discharging the patient from care, or are they renewing their 6-week course of treatment? Kind of different recommendations along those lines. The next one that I have is occupational therapy records. So a lot of this stuff kind of is going to duplicate, so I might go a little quicker for this one. But the big difference so I said physical therapy does mobility, larger body muscles. Occupational therapy works on smaller muscles and upper body. So this is more thinking about your activities of daily living, your fine motor skills, so your ability to use your hands. And they also do some cognitive function as well. So thinking of physical therapy, think of them as getting up and moving, gross motor skills, walking, navigating stairs. Can you drive? Things like that. That's physical therapy. Occupational therapy is more, can I dress my upper body? Can I bathe myself? Can I prepare a meal now? Do I have dexterity in my fingers? Can I pick up pills? Can I take my pills? And then cognitive function. They can do a lot of mini cognitive assessments. It's not as detailed as you might get with a psychiatrist or a neuropsychiatrist, but they can do a very kind of a baseline if your patient is having some cognitive issues. So just like physical therapy, you can find it's non-invasive medical care, can be done in conjunction with or after or in place of surgery. They often will order the same 1 to 3 times a week for 6 weeks. And then you're kind of pulling the same information from the medical record. So if you're going to go in there and focus, you're going to pull out functional deficits. They just might be a little bit different. They might talk more about bathing, dressing, toileting. Cognitive deficits definitely are going to be a little bit more detailed in an occupational therapy record. Or equipment might be different. An occupational therapist might recommend equipment for like a shower chair or a commode, grab bars in the shower, things like that. You might not find that in the physical therapy notes, but you'll find it in the occupational therapy notes. Both should have details about the prior level of function, their tolerance to therapy, and then any future recommendations that the therapist might have. The next one is speech therapy. This one's not as common. Speech therapy is ordered when there's an issue with speaking, eating, and then kind of cognitive retraining. So they kind of do some cognitive therapy as well. There's a little bit of overlap here. A common thing that I see speech therapy ordered for is a patient who has been either a brain injury they'll get called in for, and or a serious spinal injury where maybe they've had a tracheostomy, and they've been in the ICU for a long time. So sometimes patients have a hard time getting back to speaking. If they've got to have a trach, then we need to have somebody to get the speaking valve in place and help them kind of speak again. And then once the trach's removed, help them learn to speak again and use their vocal cords and strengthen them. Speech therapy does all of this stuff. So again, a lot of overlap here. So form of non-invasive medical care, conjunction with, or surgery, kind of not really as applicable with speech therapy. They often do 1 to 3 times a week for 6 weeks. The information that you're going to pull is a little bit different. So you're going to get information as to their speech, how they can eat, can they eat food? Are they choking on food? Can they actually chew? Can they swallow? Do they follow commands for that? Cognitive deficits. So how are they functioning? How is their speech? How's their memory? Long-term, short-term, kind of basic information along those lines. Cognitive deficit therapy, you'll see speech therapy can be a part of like a brain rehabilitation set where their main focus is on cognitive deficits. They might need some equipment. A lot of times speech therapy doesn't recommend a lot of equipment, but sometimes there can be. So if there was a tracheostomy and that's permanent, they might have a speaking valve or things like that. You'll get the information on their tracheostomy. So if you've got to have maybe a life care planner, figure out how to cost that out. It might be helpful to make sure they have these records and know what kind of tracheostomy they have in place. Details of their prior level of function. So did they have any issues with speaking, swallowing, or with cognitive function prior to the accident? And then their recommendations are therapy recommendations, therapeutic exercises. And then also what they do is they can do diet orders. So if a patient is unsafe to eat a regular diet, but maybe they can have a pureed diet, a speech therapist is going to be the one to say that. Or maybe they're not safe to eat at all and they have to have a tube, essentially be tube fed through their stomach. And so speech therapy would be the one to make those recommendations as well. One of the more common ones that I see kind of neck and neck with physical therapy is chiropractor. A lot of patients like to go to the chiropractor, especially if they've, kind of hurt their back, not necessarily like a spinal fracture, because nobody wants to manipulate that, but soft tissue injuries, they often will go to a chiropractor. Chiropractors focus on alignment of the spine to treat all kinds of conditions in the body. They do a lot of spinal manipulation, so that's the actual like cracking. But they can do some other things like ultrasound therapy, heat therapy, massage therapy. Some of them do physical therapy as well. So you might have somebody see chiropractor, but be getting therapeutic exercises assigned to them as well. So always helpful to kind of look at the recommendation section of that. Again, kind of the same thing. So non-invasive care. It can be done in conjunction with or independent of surgery, often 1 to 3 times a week for 6 weeks. Although I find chiropractic care can last a little bit longer. Their treatment course can go a little bit longer than physical therapy or occupational therapy. It just depends. And then the things that you're finding are they go through a lot of symptoms, they have a lot of physical findings, functional deficits, they definitely go heavy into that. Tolerance to therapy, they can monitor the progress. Chiropractors sometimes will order or even take their own imaging. So helpful to look in that objective section of their note to see if they've done imaging or if they've had outside imaging that they're referencing. And then future care and recommendations. So they sometimes will recommend that they add another therapy, or maybe they say, we've been doing chiropractic therapy for 8 weeks now, and the patient isn't getting any better, so I'm sending a referral to an orthopedic spine surgeon. And so now we know we should be looking for orthopedic spine surgery notes. Acupuncture, I don't see this one as often, although it is becoming more often. So this is kind of a Chinese medicine technique, works by inserting needles into certain places in the body to manipulate the internal energy. They can also add like heat therapy. It kind of depends on other skill sets that the practitioner has. And all of the same things as all the other providers, kind of goes through here. So 1 to 3 times a week for 6 weeks. You can have symptoms, physical findings, acupuncturist, they don't go through a lot of their physical assessments are a little bit different because they're kind of looking at different things than the other providers. So sometimes I find that their their assessment findings are, they're just not something that you would expect to see in all the other therapies. They're just very specific to acupuncture. And then, but you can also look at future treatment recommendations regarding acupuncture, but then also are they recommending that they see a surgeon? Did they recommend they go back to their doctor? Are they recommending further acupuncture therapy for the patient and information like that? So social worker and case management, sometimes they're one and the same, sometimes they're different. These can be involved in larger cases. So like maybe like a large brain injury case, they might have a case manager who can kind of help the patient navigate all of these different providers because it can be so much to be able to navigate all the different appointments and following up and making sure you're taking your medicine, making sure you're refilling your medicine, and things of that nature. They also, you can see that they will help patients get connected with or recommend community resources. So anything in their community that they might need, maybe like ride shares to doctor's appointments. They could recommend places that they could get some equipment for the home or home modifications, help them access affordable care, insurance benefits, and then they also can do psychosocial support and more. Social worker case management, so like large cases, you'll see these records. But then also you'll see them in the hospital a lot of times because we're setting up ready to discharge a patient. And so we need to make sure that if they need rehab, we need to make sure that we're getting the referrals and things like that for rehab. The only thing I didn't mention is family medicine. A lot of people overlook the family medicine, and I'm sorry, I don't have a slide for this, but never overlook the family medicine. So that's their primary care doctor. Could be family medicine, could be internal medicine. They're kind of one and the same. I always recommend getting those records, especially with pre-morbid records, because that can give us information on the patient's prior level of function, especially related to like even their blood pressure, and we're looking to see, how are they trending as far as pain, signs of pain. You can kind of compare the before and after, and also primary care a lot of times can be like the hub. So a patient might go to see primary care after the hospital, and then they've made all of these referrals to different providers. And so you can then kind of keep track of what providers they've been referred to and then chase down the medical records and the treatment from there and kind of go, down your different rabbit holes as you will. So always make sure you're looking for primary care records. Some patients will have them, but a lot of patients won't. Some people don't go to the primary care unless, they go somewhere if they've got a cold or they need to see a doctor, but they don't have a primary doctor that they see all the time. So they may or may not have this, but if they do have a primary care, I do recommend if you're plaintiff or defense, all of this stands in this, by the way, but you should definitely get the primary care records. Okay, so how to identify missing medical records. So one of the things that when we're reviewing medical records is there's always things missing. Some things that I've noticed, you can get a lot of times things will come to me and it's just the after visit summary. So the printout that the doctor gives you, and it does have the recommendations. It'll say, take this medication this many times a day, or follow up with this doctor. You have an appointment on this day. It does have helpful information, but you want the medical records that the actual doctor wrote. And so that's one key thing. So if it's an after visit summary, you want to get the corresponding medical record. That's one way. But some other ways that I look, so when I'm reading through the subjective section, so where it's what the patient has told us. So did the patient reference seeing pain management? Did the patient reference having a procedure? Did the patient reference trying a medication that they from another provider? So that tells me, one, that they tried a medication related to their pain. So that's one thing that we should be keeping track of. But then also they saw the provider, and so that's another missing medical record. You'll want to get the records from the provider who prescribed that. So the subjective section is really helpful. The plan section can go tell you about recommended referrals. So like I mentioned before, are they recommending therapy? Are they recommending they see another specialist? Imaging, did they recommend they have an x-ray? Did they recommend an updated MRI? Did they recommend any treatment? So is it a pain management doctor and he recommended that they go have a spinal block? Those are all kind of my cues that I need to kind of look and investigate to see if the patient had this. Sometimes as the reviewer, I don't always know. It might be something that I'll set off to the side and have somebody ask the client, did you ever go to physical therapy here? Or I might find my answer in records later on that say patient never went to therapy. That sometimes can be helpful as well, because then I know, I'm not going to look for those therapy notes because it looks like they didn't go. Billing records are one of probably the most underrated ways to find out if I've got all my medical records. I like to review the billing and the medical records together because then I can cross-reference either way. But if you've got a bill, right, if a orthopedic surgeon sent you all of their bills and you notice that you only have 3 of 6 medical records, but they billed for 6 visits, now I know I have 3 more visits that I should get records for, because that could have information in there for us. And then you could always ask your expert witnesses or nurse consultants if you have a nurse paralegal on your team or a nurse just reviewing records for you. They might be able to just have some insights on what is the expected course of treatment. Like I mentioned, I think earlier, I'll just reiterate here. So if a patient, they're saying that the patient had a fracture. Well, you can't diagnose a fracture without an x-ray. And even if the fracture is sticking out of the bone, we still need to have some sort of imaging to find out the extent of it before they go operating. So we're definitely going to need that. Any kind of brain malformation, I'm expecting to see a CT or an MRI, different things like that. So you can always ask your expert witness if is there anything any records that you think that we should be getting? They should be telling you, but just in case. Obtaining medical records, be specific when you're asking for them, include the dates, and these are on your HIPAA forms. A lot of you will do basic HIPAA forms and the patient signs it and then you fill them out. But making sure you're specific, making sure you're including dates, always ask for the billing records, and then as things come in, just kind of reevaluate there. Let's see here. And then I think I touched on this here with the billing records. So if you have an office visit or a procedure or an imaging or a test, you should also have a bill. If you have a bill, you should also have the records. And so I like to go through and kind of cross-reference and make sure that I have everything together and we don't miss anything. And then medical records issues, really quickly here. So handwritten medical records can be difficult to read. I've read depositions where they've asked the doctor, can you read this? Because I don't know what this says. And the doctor's response is, I have no idea what that says either. So their records can be really hard to read. When I first started in the medical field, it was all handwritten records. And it was really difficult to kind of read things. I gave you an example here of a signature. That's probably a real signature. And that's how some of them write and expect to be able to know what was going on there. And then we have tampering with medical records. This, like I said, is more in medical malpractice. So things you're looking for, just really quickly, if you had any concerns, were multiple versions. It'll say like version one, version 1 of 2. Make sure you have both versions. Addendums are signs that they've gone in after the note has been already electronically completed and signed. So they've gone in to change something or add something. A lot of the times it's innocent. They've just had gathered more data or just remembered something, but sometimes it can be malicious. Redacted text. I've seen things come through where it's just redacted. It says redacted and it's all been deleted. They should have it X'd out where you can still read it. And then you can also have people look at the electronic data, because if it's electronic, every keystroke has been recorded somewhere. And so there are experts that can kind of look at that back end information. If you have any questions on these slides, is my information. If your paralegal's having issues getting medical records and just wants to ask me a question, or if you have any questions, you just feel free to reach out. That's my email and my telephone number there. And so, Bryn, are there any questions?
Yes. So one of the questions is, what is the best way for the patient to correct an error in their medical records, especially when dealing with a large health system where the error is found in several places within their records?
That is a really great question. So the best way to go about that, the first thing to do would be to bring it to the attention of the provider. I've had patients call and say, hey, doctor wrote right instead of left. I noticed that on my medical record, especially now where there's electronic, there's these like my charts where patients can actually read their own records. They'll call and hey, can we make a clarification? It should be addressed by the provider. And it could come through as a change in the form of an addendum, patient, this was a correction. It kind of depends. If it was the provider's assessment, the provider could come back and say, that was my assessment on the day. I'm not changing my assessment. But if it was something like the patient told them information and they transcribed it or translated it wrong, what I would have your client do is to call, and it'll either be, maybe they'll change the record, but at least if they call, they're going to make a telephone documentation. And so you could always request the telephone records, and you could get the documentation that the patient or your client called and requested to make that change and said, I noticed there was an error in my medical records. This is the corrected information. And if you request those telephone records, you should have their documentation on that as well. I hope that answers your question.
Great. And then the next question is, can you talk about the differences between psychology and neuropsychology?
Yeah, so psychiatry, psychology, and neuropsychology. So they kind of look at the same thing, right? So it's like the function of the brain. And so since we, as healthcare professionals and humans, don't really understand much about the brain, even though we understand a lot, it can be really difficult to understand. My basic as a nurse, how I kind of think of these guys, and you could ask a psychiatrist and they'll probably give you a much better explanation. But as a nurse, psychology is more, I think of like talk therapy, kind of going for anxiety, depression, PTSD type symptoms. Psychiatry is more the kind of the same thing as psychology, except they are doing medications. So they're going to prescribe psych medications. They can do, things like schizophrenia, personality disorder, anxiety. sleep disorders. So they're kind of more, they can do the same things as psychotherapy, but they also handle a lot of the prescribing of psychiatric medications. And then neuropsychology is more of like a function. So how are their executive function skills? How are their math skills? How is their reading and writing skills? How are they able to interpret speech? How are they able to kind of function on a day-to-day basis? How is their attention? How is their memory? Neuropsychologists a lot of times will do testing, but some of them will do talk therapy and have them come to do more therapy, but a lot of the neuropsychiatrists will do just the testing, and they'll maybe recommend like every 5 years they'll have to come back and be retested. But that's kind of how I differentiate. So psychology is more talk therapy. They can diagnose, and then psychiatry, same thing, but add medications in there, a little bit heavier on the medicine aspect of it. And then neuropsych is more of functional, like how can you function in the world now? Like how can you manage your finances? Can you work? How can you, what is your reading and writing skills? Things like that.
Great. That about wraps up the questions.
Okay, awesome. And unless there are more questions, I didn't have anything else today.
All right. Thank you so much for your time. We really appreciate you giving us this presentation.
Yeah, thank you.
You may be eligible for CLE credit in your state. Visit bhba.org/podcasts for more information.